I greatly appreciate the opportunity to be part of this conversation today. The healthcare industry has really been turned upside down over this past year. Challenges are coming from all sides: how to provide traditional services to our patients in need, how to better communicate with our patients, and even how to address many of the new unmet social needs of our patients and our residents in many of our facilities. All of these challenges push us in the same direction: the need for really looking at a sustainable telehealth solution. Today, Cindy is going to walk us through a conversation on this very topic. So with that, because she's got lots of great information, I'm going to turn over the conversation to Cindy. So thanks, Cindy, for being here to present for us today.
Rob, thanks for the invitation. I truly appreciate it. You know, like you, as I think about the U.S. healthcare system over the last few years, it certainly has been struggling. It's been struggling with rising demand and spiraling cost. The reasons are many, a few that you've just mentioned. Certainly, though, there's provider shortage and burnout. Aging population continues to have chronic conditions and complex needs, and that's ever growing. And then while the life sciences have done oodles in order to actually help us better manage diseases and conditions, the reality is those are sometimes very expensive solutions. And so throughout this entire time frame, we've been talking and hearing about transformation, and that's really been our battle cry. Many believe that technological innovation and digitalization would actually respond to address these concerns and concerns around scalability, complexity, and constraints. But the reality is that despite all of these hopes and dreams, of the advancements have been quite slow. Telehealth had actually taken not quite the hold that we had hoped for, and in fact had only been growing at a rate about 3% annually among all of our providers. And then along comes this public health emergency, right? A pandemic, catapulting adaptation and telehealth adoption like we've never witnessed before. It's really been a watershed, and it's enabled changes in regulations and reimbursement, at least for now. But this accelerated fashion, for many at least, really involved unsustainable choices. And so today, as you mentioned, we're going to take a look at that and see what we need to do now in order to be ready when the COVID pandemic is over. We identified 4 particular objectives we're going to try to accomplish during today's conversation. But first, I'd like to talk about the history of telehealth. Now, my first exposure, perhaps different than yours, wasn't aligned with the historians and their perspective of telehealth and virtual care provision. Rather, mine was quite different. It started with the Jetsons and actually Hanna-Barbera. I saw the Jetsons probably in the 80s. I don't think I saw it in black and white in the 60s. And the reality was I was quite enamored as a young nurse with the concept of having a doctor that would peer through a video screen and give care to gosh, I just forgot his name, but the Jetsons' son. And then from there, I went to actually thinking about Charles Schultz and his adaptation and using Lucy Van Pelt and her modern approach to providing psych care. Those approaches, by the way, may appear very greatly, but the truth of it is they possess similarities, especially in regard to desired outcomes when done by true professionals. And really, that's how it is today. So let's start a little bit, Ralph, by level setting. When we talk about telehealth, the question is, what are we really talking about? And I would tell you that the definition of telehealth depends on who we're asking. The truth of it is telemedicine and telehealth is defined differently by different organizations and different providers. Traditionally and generally, I would say, they would align that telehealth is the overall infrastructure and telemedicine is the delivery of actually healthcare services. But from there, again, you'll get great variety. Additionally, if you talk about who can provide services in telehealth and where can it be provided, the truth of it is that it depends a lot on federal and state regulations and medical licensure and practice acts, as well as the individual physicians of all of our clinicians. And by the way, the same variability occurs when we talk about reimbursement. Ask me if it's reimbursable, and I'll say who's the payer and where are you providing the service. And then I can help answer the question. Regardless of all those differences, though, telehealth generally can be agreed to be part of one of four types. The four types are live or asynchronous. This is your video call, or today, even your audio telephone call. Store and forward, that's when you capture information. It can be medical record, it can be x-rays, and send it to another clinician for their input and perhaps their participation in the care planning. There's remote patient monitoring. That's usually what happens whenever we're looking at managing someone with a chronic care illness and trying to keep pace of what they're doing and to be preemptive and helping them avoid hospitalizations or rehospitalizations, or frankly, just complications. And then there's mobile health. Mobile health is what we generally think about when we're doing group messaging for education. And those, again, are very simple definitions of real complex terms. But the truth of it is there's a lot more to telehealth than audio visual and audio video. That's actually what I believe most people think about. But as you referenced up front, Ralph, the reality is there's also administrative responsibilities that can occur. There's a lot to do with certainly then exams and care delivery, but communication, care coordination, and management, especially, by the way, for our high-risk patients, the ability actually to intervene, not interfere, but intervene for them at critical junctions of their care in order to help offset bad outcomes can certainly occur through the use of telehealth. There's a lot of other ubiquities and differences actually when one talks about telehealth. We can ask questions like, what sectors can it be used in? What are the various settings? Who are the users? And then talk to me a little bit about social and clinical cases. And we're going to do that together now. So when we talk about healthcare sectors, it's typical, again, because the predominance in telehealth has really been around behavioral health, hospitals, and really medical care, so practitioners. But the reality is it's also very viable for elder care, dentistry, hospice, palliative care, justice and correction systems, and managed care organizations as well. Let's take a deeper look at these. If you talk about who performs telehealth, again, the list gets long. And by the way, this is just a sampling based upon practice acts in various states and also Medicare allowances in various states. If I tried to list it all who are eligible, I could not include them all on this page. The reality, again, is we think about behavioral health, we think about physicians and extended care professionals, but we don't honestly think about such as the community paramedics, therapists, nutritionists. But in certain environments, all of those individuals can provide such service as well. And the where is also diverse. There are multiple of settings, not just patients' homes, not just hospitals. And by the way, FQHCs don't have to be cut out of the equation totally. The reality is community organizations, various facilities, schools, and other such facilities are actually appropriate environments for the delivery of telehealth. I hope just through this brief comments that it's opening up your thoughts in regard for how you might be able to have a more broadband telehealth program. In 2019, certainly before COVID, if you can remember back that far, sometimes I'm not sure I can, the reality, Health Affairs did a survey to determine who the most frequently providers were that were utilizing telehealth most frequently. And as you noticed, probably not what we wouldn't expect, at least for the top one on patient care, it was on-demand urgent care. Generally, by the way, being provided either by very large physician groups or entities like American Well, Teladoc, MD Live, and the such. After that, radiology, which by the way, probably has its earliest history in telemedicine, and then behavioral health, and you can see the others listed there. Physician to physician, emergency care actually was at the top of the list. And RPM, nephrologist and cardiologist, I don't know if you would have expected that or not, were also at the top of the list. However, total utilization was still pretty low. The least frequent utilizers, again, were these three sets of providers. When COVID hit, and certainly somewhat before, but not very actively, the use of telehealth for social uses, as we would call it, or virtual visitation, actually became in vogue. The reality is that we needed to do something because, as you know, the opportunity for visitation was ceased in many organizations. So providing or bringing in some type of technology. Now, a lot of people tried to do this, of course, with a cell phone in their hand, a tablet in their hand, or very large cart systems. I have to say, I'm proud to be of an organization that had a different strategy, again, by the way, which is pictured in that lower picture on this screen today. But the reality is not doing so, again, ended up creating a lot of psychological distress, depression, loneliness, isolation. And by the way, that permeates facilities even yet today. And so again, learning how to actually employ visitation through telehealth, through excellent technology, is an excellent option for people to consider today. I believe a lot of the stumbling, though, and the resistance is the fact that it isn't reimbursable. And we'll talk more about that a little later. There's a myriad of clinical use cases. Again, I've listed just some of them here for you. And these are really by topic and not by detail. I guess what I'm hopeful to, again, promote is, if not during this time together in this conversation, that subsequently you might again look at this list and actually say, which ones of these might we want to and maybe should we be providing? So the face of health of telehealth has changed. I would not have thought, given my 40-year career, that I would think of telehealth or any other thing in healthcare as being divided into pre-COVID, during COVID, and then after COVID, but such is life. And so the reality is, let's take a look at this. And again, we're not going to go through each of these slides that follow, actually through slide 41 in great detail. It's again here for your information. But anybody who knows me knows that I don't like to do a presentation and not provide all the information that I can. So the reality is that pre-COVID, I believe telehealth was pretty much looked at as optional. It was sparingly used. It sometimes resulted in fragmented care, silos of care, and frankly, lack of continuity. There wasn't a whole lot of consolidation between the providers or communication, and all the consolidation that was occurring between the providers and the payers really weren't helping in that regard. Consumer demand was high. Convenience and access was strong. In fact, nearly as strong as it is right now. And the desire for technology and the usage of technology and the internet of all things in their personal life made people wonder why healthcare wasn't employing technology as well. But telehealth, again, predominantly was used for urgent and episodic care. Interestingly, in those early days, patient satisfaction was pretty high, in fact, higher than people would have expected. And seniors, while it was doubted they would use, were actually one of the highest groups in adoption of telehealth in these pre-COVID days. Reimbursement, however, and regulations existed in such a way that it created a lot of barriers, I believe, to the deployment of telehealth. It wasn't about available technology. It was more about regulations and reimbursement. Therefore, when telehealth was implemented, it was done with an eye to short term. It was, what do we need to get out of this now? And unfortunately, telehealth became as much of the solution as it also was the problem. And then the pandemic hit. When the pandemic hit, everybody scrambled. The reality is, telehealth usage became explosive. It was aided, of course, by HHS and their waiver of HIPAA. The pace accelerated like never before. It became adoption by necessity. Patients and staff were needed to be made to be able to be safe, to be able to receive care. And so changes occurred and changes happened quite swiftly. Telemedicine was used in various ways. It did not then really vet data security or workflow or even scalability and user ease review. The reality, whatever was available, whatever could be afforded, was often employed. Even places like Mayo Clinic, who had actually put tele in place prior to COVID, actually, though, came out and took a position and actually said that if it had not been for COVID, the reality is they would not have transformed and they would not have grown their telehealth program as quickly and with as much success as they have since. The truth of it is that significant leaders and thinkers, and certainly renowned organizations, realized that they needed to endorse telehealth, not just to stabilize and to build their revenue, but to truly be transformative. They needed to offer efficacy, satisfaction, and deliver outcomes. I wanted to take just a couple moments and share with you a few of the facts that compare pre-COVID and COVID timeframes. There's a lot of comments made out there about what actually has occurred numerically. And I wanted to share why we may have different numbers coming on at us. The reality is, and again, I have 2 pages here of data that has been drawn from surveys from different organizations conducted throughout this time frame from January through November of 2020. And you will see that each of the surveys and each of the references here actually provide a little bit of a different twist. Harvard says that only about 8% of care was delivered via telehealth prior to COVID. The CDC actually, when it was looking at the usage of telehealth and looking at encounter data during the first 3 months of this year and comparing that to the same 3 months in 2019, they said that telehealth usage was already increasing by 50% in 2019, and then another 154% increase over for the first 3 months of this year. So 50% and then 154. When practitioners were surveyed, again, we saw varying numbers. I hope what, again, you're starting to recognize is part of the answers and part of the variances that we're hearing is based upon the way the questions were asked and to whom the questions were asked. So again, in 2019, Health Affairs reported that 15% of physicians worked in a practice that conducted telehealth. And that 11.2% used telehealth to connect with other physicians. Again, in each of those studies, again, it's interesting to note that the majority of folks who answered affirmatively actually were in large practices. And by the way, that continued to be the case. Providers continued to report escalation in usage, and we're going to look at a couple of graphs that depict this clearly for us. The reality is, too, the AMA, their VP of Digital Innovation, reported actually that 14% of their numbers actually used telehealth in 2016, 28% at the beginning of 2019, and then it was estimated that 60 to 90% of their membership was using telehealth during the first half of this year, and that more than half of those were actually first-time users. That's pretty phenomenal. And when we talk about service expansion and how telehealth is being used, it indeed escalated in some regard because CMS temporarily approved 80 new services that could be rendered. And Medicare Advantage plans also kicked up their opportunities and the services that they were also rendering through telehealth. The estimates then for what telehealth revenue could look like actually were estimated to grow from being a $3 billion industry to over now $250 billion. A few slides of a few pieces of information from a couple of these studies. Class asked providers, and now this was September, so now we're well into COVID season, in regard to the biggest challenge that they had confronted when COVID hit. And you may see there on the left that telehealth was the biggest concern that physicians identified, or providers, not just physicians, but providers identified as encountering, and the ability to deliver remote patient monitoring services next. You may also notice on the left, on the right-hand side, that telehealth was also the quickest resolved, and remote patient monitoring was the least resolved. Another study by IQVIA, they collect an awful lot of data and do reporting. IQVIA reported, again, they were looking at patient visits and the types of patient visits that actually had occurred. And again, this study was taken, or the data rather was collected and given to us based upon claims data that they were able to compile for all organization types in middle of June of this year. And if you notice, again, all types of it, notice the dip in blue there that occurs, as we may have expected during the early pandemic season when offices were closed, essential services only were being received. And look at how the inpatient visits dropped even more. So the distance between the blue line and the orange line, that's telehealth. And that's what's happening in telehealth. This is a recent slide. I actually received this data just 2 days ago, and it was so important. I wanted to go ahead and put it in here for us to look at together today. This actually is also IQVIA data, and they actually shared 2 days ago, released this information that actually shows the weekly medical claims in offices, institution, and then telehealth claims versus the baseline. And again, I could spend a half hour alone probably talking about this in a couple of other slides, but let me give you just a couple of highlights. Notice that the baseline, by the way, is up here at the 0% line. See that gray line running through on the graph on the left-hand side? And as you notice, all those blue bars are telehealth services that have been provided from March through November. And as you can see, they far exceed the number of office or institutional services that are coming through in claims data. And if you look at the data on the left, you're also able to see what we've actually done is look as a percentage, and this is a claims by service type. So again, 11% of all claims being telehealth, 20% institutional, 59% office. And that's pretty interesting because pre-COVID, our telehealth claim percentage ran somewhere between 1% and 3%, depending upon the geographical location. So if you look at year-over-year growth of institutional and office medical claims, again, note that gray line through the middle of each of these bar graphs. The top, by the way, is our institutional claims, and the bottom, again, being our office medical claims. We have not yet hit, other than one funky week here, somewhere around the 35th week, we have not hit baseline yet. That means, by the way, we have a lot of people not getting care. Now, does that mean that they shouldn't have been having it? Does that mean that we're backlogging people that need care? Does that mean that we're going to have a run on care later? Does that mean that this is care that can't be delivered through telehealth, and so people are waiting? Is this all simply non-essential care? Those are all great questions, and some of the why behind all this cannot be fully satisfied by looking at the data. What we do know is that if we look at the medical claims year over year and look at the growth, again, in telehealth, you can see, as anticipated or would have been expected, we had a huge high upspring in April and in May. And as offices started open and changes started occurring, we actually had a downtrend in telehealth growth, but the reality is it's still far above. In fact, it's over 4,000% greater than it was pre-COVID. So one of the questions I ask about care that hasn't been rendered is if it's possibly related to elective procedures. This data would tend to indicate perhaps it is, because on these actually four different areas of surgeries that are looked at or procedures that are looked at, you can see that for the types of procedures and the topical classifications of these procedures, we are extremely underrepresentative as compared to a year ago and what we would be expecting to incur and to be delivering for elective procedures in all categories. Ambulatory visits. While I already mentioned to you that, again, we've had swings and pendulum, the other piece to that is the fact that, as you notice, there is some regionality. And so, again, we have had a higher usage of telehealth in our Northeast location, and then in our South, and then I'd say the Midwest and the West are kind of coming in last. Overall, again, this is our ambulatory curve, and then how it looks again, both in office and in telehealth and in total visits, again, by area of the country. And then I always wonder, well, again, is something happening particularly with particular provider specialties? And the reality of it is that, yes, we do have some prevalences. Pediatricians actually have the largest baseline change from pre-COVID, followed closely by pulmonologists, and then behavioral health. Behavioral health, it's been suggested, the reason that we don't see such a huge gain with them is because, again, of the tremendous use that they had pre-COVID. And then again, this slide will be available to you. And so again, depending upon your area of specialty, I saw we had some urologists, for example, notice you're kind of down in the third of the pack in regard to usage. Again, we do have a decline occurring now as COVID season again has prolonged itself, and offices have been seeing more people within. But again, 4,000% increase overall. And when we look at the delivery of telehealth, we have to ask, how's the consumer doing in all of this? Are they all right? Remembering some consumers would tell you they really had no choice. If they were going to see their practitioner, they were told they had to do it through a telemeans, whether that be on the phone or in audio video interactions. Others, how would tell you that over time, and if you look at results of studies done with same individuals over the course of time, there is increased favorability toward the usage of telehealth and the receipt of telehealth. 76% as compared to 2019 say that they are interested in continuing to use telehealth going forward. And providers again, we're seeing somewhere between 50 to 175% increase using telehealth to fill the gap. And approximately 57% of providers report that they are now more favorable to providing care through telehealth than they were before. 64% rather saying that they are more favorable, more comfortable with using it, and 57% saying that they are more favorable towards using it. Those are tremendous numbers. I want to hasten back to the comment made earlier in our conversation, and that is the fact we have never seen such change and such adoption of anything happen so rapidly as we have during COVID season with telehealth. And here's that slide that represents our financial situation. Again, it's being determined that approximately $250 billion of services being rendered today in Medicare, Medicaid, and our commercial populations could actually be delivered through telehealth. The amount of those by type of care, again, as you notice, is identified below. So when we talk again about physical healthcare cost, again, it's interesting again to look at the breakdown of the care that's being rendered and the average spend per member. And this is a graph again that shows the relationship between someone that has a behavioral health condition and not just the cost of the behavioral health care, but their physical health care. In the COVID season, we repeatedly hear about patients incurring isolation, depression, and that the behavioral impact is significant. I hasten to bring to you that social visitation piece that I mentioned earlier becomes extremely relative when we talk about the potential decrease of potential cost in treating people's emotional and behavioral illnesses related to COVID. So the employment or deployment of telehealth to help assuage people's emotional states can have significant financial implications for all of us. So telehealth, without a doubt, has its challenges. Some of these, again, are not something that you would be unfamiliar with. Whether we're talking about the provider and his negative feelings toward it, or the fact that it simply doesn't feel like it fits his specialty because he needs to have more hands-on time, or whether you're talking about the patient and their reticence to it, or their discomfort with video, or simply just the fact that they don't want to use their data plans in order to pay for healthcare minutes, or whether you're talking about technology because it's too difficult, too costly, and there's HIPAA and privacy concerns that you don't have how to overcome. Again, there's all kinds of reasons why people avoid the use of telehealth. This, by the way, happens to be one of my favorite cartoons about why you may want to use telemedicine. There are also concerns, and we don't hear as much about compliance and legal restrictions and concerns, malpractice, fraud, licensure, and again, regulatory realities. But those are the realities that also create barriers for implementation and actually affecting any strategy. There's also reimbursement, which we know is greatly inconsistent among our payers, and then a host of operational concerns we need to be thinking about. Which brings me to the point, so why would we do it? These happen to be probably the most commonly stated reasons for why we ought to do telehealth. And the reasons are all of these do invoke excellent outcomes. There's great efficacies and proof. Many studies and many organizations pre-COVID and during COVID would reinforce the usage of telehealth to recognize and to realize these type of achieving these types of rationale. However, there are true business reasons. Telehealth makes good business sense. It actually grows business, it increases revenues, there's new lines of business. Rather than giving away advice and follow-up and check-in appointments, providers can actually charge for those. Utilization of text messages with certain payers for particular circumstances can be reimbursable. We know that Medicare again changed its care management and its transactional care management coding, and now the usage of telehealth is being referenced for deployment for those, not just now, but in the future. And there's opportunities for downstream revenues. However, in addition to those challenges, there is challenges for long-term sustainability. So there's really is a double dipping concern here. And I'd say the 5 most common categories for challenges for long-term sustainability. So Cindy, we've employed or deployed a program during COVID. We intend to continue with it, but these are the top 5 things that I'm most concerned about. We're going to talk about those. However, I want to make a general comment. And my comment is that deploying telehealth and believing it's going to be sustainable and doing that without a true strategy is naive, and at best it's hope. The real reality is many providers went into the pandemic without any plan, frankly, never even intending to ever use telehealth. And now they're questioning if some of their services can actually be maintained with the equipment that they're using. They're asking, how do I keep this investment that I've made with these PPE dollars actually and get a return on that? And they're asking questions like, how do I measure outcomes? What outcomes am I achieving? Because they haven't been collecting any data during this time. It's simply been too chaotic. So I would suggest to you there are three key variables that we need to be concerned about when actually we're looking at developing sustainable telehealth solutions: process, people, and technology. And if we want sustainability, by the way, I believe that sustainability means consistent value over the long time. So let's talk about people. We need willing, determined change agents, champions, people that will persevere, people who simply like convenience and simply want to do this because, again, it's in vogue, and then want to move on to the next trend or fashion, whatever that might be in healthcare, probably aren't into sustainable solutions. We need to remember that there were 3.6 million people who missed an appointment on average, at least that's the estimate, in 2019, because they didn't have transportation in order. So they had a transportation barrier. 3.6 million that telehealth may have been able to help. So when we talk about people, there's three at least key stakeholders. That's your patient, your provider, and then whoever you're working with, the other stakeholders, be that vendor, be that your IT team, and others, to actually create a sustainable solution. There's also process. We talk about process, we want processes that are budget focused and focused on outcomes. We need to somehow try to make up for the loss of a human touch. We need efficacious and effective processes that are efficient, that are proven. We need performance-oriented outcomes. I can't say that enough, with metrics, monitoring, measurement, reporting, and then improvement. Without all of that, there will be no sustainability. We also need excellent technology. Technology meaning we need security, we need encryption, we need tools that offer HIPAA compliance. Despite all the questions about what's going to be continuing after COVID, the one consistent feedback that I find in everything I read, no matter who's the author, is that the HIPAA compliance waiver that HHS enabled is not going to be sustained. The question of when it will be pulled back is unknown yet, but that's, everyone seems to be in uniform opinion about that. So again, the reality is, if you've already invested as an organization in tablets, or you're using a platform that is not HIPAA compliant, how do we or phones, I'm sorry, I said tablets, but I meant phones. How do we convert that investment to something that is sustainable? What is the vendor? What is the technology solution that you have in mind? What are you considering that indeed can continue to maximize that investment for you? And by the way, not all vendors can do that. We also need to be thoughtful about the multiple communication. I listed at the beginning of our conversation all the various ways that telehealth can be deployed. What are the ways and the uses for which you're going to deploy it? And then, can your technology actually support that? Is it in concert with clinicians and not just engineers and developers? Can you support all the facets of telehealth and not just audio-visual modalities? Again, I remind you of that 21% result that the class study found in September regarding interoperability, of that being, I don't know if you had time to look at that, but 21% of the respondents cited their third concern was interoperability at 21%. Interoperability, by the way, does not mean integrated. So it doesn't have to be integrated into your EHR to be interoperable. And organizations like ours and others are able to help take what you utilize and create interoperability. On that note, I wanted to speak for just a minute about the issue of standalone versus EHR integrated technology. The reality is that both have pros and cons. And I trust that as you would put together and formulate your strategy and look at whether to utilize perhaps an integrated component or solution in your EHR, or to even purchase an EHR that has that component, if indeed there is value for you in a standalone option. Again, these are some of the key points, again, found in literature that support both the pro and con advantage of being standalone versus integrated. I borrowed from the AAFP, the American Academy of Family Practitioners. Actually, this is their process for transforming a practice to support a sustainable telehealth solution. I didn't pick it because it was AAFP's. I chose it because it's so reflective of the universal thoughts of the steps that are needed in order to develop a sustainable telehealth strategy. The reality is the belief is that a new model will exist in coming days that will be actually a hybrid delivery model where both inpatient and in office and in hospital and in facility, as well as teledelivery or telemedicine, will be employed, and both to their fullest capability. That our new world will look very robust, and it's not going to be a one size fits all. And that fact, telehealth, though, will continue to be a bit of the lifeline for practices and providers to sustain those patient relationships regarding access and communication, commitment, care plan, achievement, and financial viability. There are many predictions out there for the post-COVID era. The reality is that, again, if I've put oodles of them on one slide, and I could have taken up several. The question is, though, how will your practice, how will your organization actually practice and fare post-COVID? Do you have sustainable strategies that are going to fortify your opportunities for success? I provide you a couple of cautions. Those cautions would be, you're going to need to reinforce your customer expectations. And don't think for a moment that after having given good access and letting people actually talk to you on the phone and actually not have to travel at all to actually get the health care they need, that people are going to be quick to want to give up that convenience. Convenience is one of the key things that drives consumers today. And we're going to have to figure out how to deal with that. In regard to HIPAA, I've already mentioned the opinion of people wiser than I that the HIPAA waiver will be rescinded. I would encourage you to look at your security risk analysis, look at your notices of privacy, determine again and ensure that you have provisions for how to align those and to make sure that they are appropriate with whatever telehealth strategy that you are developing and you inevitably deploy long term. Look at the fact that let's all be reminded that CMS can't, there's a lot of comments out there that CMS will just change things. CMS, by the way, can't change HIPAA. I just want to be clear on that. HIPAA is actually part of the Social Security Act, and it literally will take an act of Congress for anything to change long term. So instead, we will see CMS do things like they did already for 21, which is developing new codes and approving codes and reimbursement and making reimbursement changes rather than getting into the areas that they actually do not have authority. I would also remind you there's a lot of regulatory realities that we have to confront. I mentioned to you with this great increase, again, it was estimated by OIG that the number of weekly claims for telehealth have risen from 13,000 a week to 1.7 million a week. Therefore, the emphasis on fraud and abuse is going to occur significantly in 21 and beyond. We're going to be looking again to ensure that complexity and time is documented and to support your claim for telehealth services that are rendered. Connect the Health Act, again, has not yet been passed. As you know, that again would create some additional enhancements with CMS. That still is open for consideration. And I am told that the DEA is currently looking at ways of actually modifying the in-person requirement and allowing telehealth long-term for the evaluations of people as being appropriate for controlled substances, and then the ability for them to prescribe them through telehealth. The other issue that, again, you hear pro and con about, and I want to share with you, is that of parity. The reality is that there are some that are going to argue very strongly that telehealth services should not be given the same reimbursement that in-office services should, and the reverse is also going to be argued. And again, I think that we need to be able to take a position and support through our strategy and through our outcome measures, again, postures, so that again, we're able to negotiate for the postures that are not just fiscally good for us, but actually are fair for all. IQVIA again put together again this slide. I just remind us that, as I stated in our earlier of our conversation, we need to think about the impetus for transformation, and that's really about escalating patient engagement. We need to be cognizant, and we need to create a strategy that helps us to understand what the patient's digital journey is going to look like in our organizations, and then deploy strategies with all of the solutions that enable that. I encourage you to remember that the patient is going to be a participant in their care more than they have ever been. And that again will occur with RPM and telemonitoring, moving down the slate perhaps to assisted home visits. There'll be virtual visits, office visits, and then of course hospitalizations. So the big question is, again, if we're going to do this, we've got to have some ROI. I again like this cartoon. Obviously, I wouldn't post it here. And in the space of telehealth, I would encourage you and promote the obtainment of data around both qualitative and quantitative returns. Here's a host of a list of qualitative returns that you might think about that your organization could actually promote to be monitored. The reality is looking at these often is about patient engagement. It's about requiring and more than just the hardware and the network and the software and did it work well, but it's about patient centricity. It's thinking about meaningful outcomes and the satisfaction and the patient experience. The reality is telehealth can change the healthcare experience into a very positive one for its recipients without having any detriment to the healthcare delivery that an individual incurs well. And then there's the quantitative returns. We all want to document dollars either that we're gaining or costs that we're saving. And so as I look here at slide 60 with you, I am reminded that we need to do this, and we need to be thoughtful about our value-based realities that existed before we went into the pandemic and will be sustained and probably ignited post the pandemic as well. So you can use telehealth to basically address things like closing gaps in care, meeting your internal or external quality metrics, perhaps things in your contracts with payers, improving your CAP scores, and other types of both operational and contractual and outcome improvement that actually will generate perhaps even new patient revenue, new service revenue, and increase then the way that you are perceived in your marketplace. In regard to cost savings, we would look at things both from an administrative burden or workflow reduction, as well as preemptively preparing for a visit, for example, with an individual through the use of your communication capability and the coordination capability on your technology, so that when a person comes into the office, you aren't utilizing valuable time to complete those tasks. And moreover, so that by the time that a person gets to the back office, it's been well known and well recorded why they're there. I guarantee you again that productivity will be increased, workflow will improve, and your outcomes will look better, both on paper and emotionally with your staff. There's opportunities to reduce urgent care, ED visits, hospitalizations, and rehospitalizations. The last comment I would make is I do believe we're headed toward a time that the brick and mortar and the emphasis on that will not have the same emphasis and focus, but rather we'll be looking at how to maximize the use of our staff even when they're working remotely. So when we think about KPIs and we're thinking about improving revenue, I've listed here for you some examples of things that our clients have actually focused on in regard to improve their outcomes, things that are able to be documented through the technology and through usage of the technology, through the solution that is being employed, and therefore gains that they are positioning for days ahead. And it certainly is something that you are able to be eligible to do as well. In summary, I would tell you that when I think about telehealth, I think that there are basically three predominant types of organizations that will exist when the pandemic ends. There's going to be those that sigh and retreat to business as usual and say, God, I'm glad that's over. And then there are going to be those that continue without a strategy, hoping to appear modern, to be able to compete, and to survive. And then there are those, I hope it's you, that's going to seize the opportunity, build sustainable solutions, and transform. I just ask you today, which will your organization be? Ralph, I'll turn it back to you and see if you
All
have
right.
questions.
Well, first of all, maybe just reach out and see if there's any questions, anything in the chat box. I don't think I see anything currently in the Q&A or the chat box, unless Amy has something that she's seen come in.
Nope, I don't see anything right now.
Well, we'll give a couple seconds there while we do that there. Again, I just want to thank Cindy for that great conversation. Telehealth has been a passion of mine for some time. And it's unfortunate it was a pandemic that kind of brought it into what we think is going to be the future of the program. With that, as I'm not seeing any questions coming in, if you have any questions that you want to discuss specifically on the content or how you can further explore a sustainable telehealth solution for your organization, please reach out to either Cindy or myself. And otherwise, have a great rest of the day. Thank you.
Thank you again.